the afternoon as we listen to three experts in patient engagement in primary care, Dr. Tirodkar and Dr. Tumiel-Berhalter and Dr. Malouin are going to be speaking to us about their experience, often with patients at our medical home and other practical activities for patient engagement. So one thing that we're going to start off today is we chose this topic based on feedback we had received from the PBRN community on important topics. They were seeking additional practical insights, and patient engagement was identified. So today, before we start this particular webinar, we are going to ask you to respond to a poll that we have on other topics that have been suggested, not only for a national webinar, but in receiving critiques of these national webinars. A common refrain has been, the webinars are helpful, but we would like a more extensive dialogue or more detailed descriptions in some other forum to explore the actual relatable experiences that may be transferable to a particular research project or implementation activity. And so we are seeking through the poll that we're going to be giving your feedback on topics for national webinars, and also in the context where we might have a supported learning group for extensions and discussions. So we'll do that in a moment. After we launch the poll, we're going to have individual presenters, about 15-minute, very concise presentations. And fear not, at the end of the presentations today, you will receive an email with the PDF files of all the PowerPoints in a prompt fashion, so you will have that. After each presenter, you will have an opportunity to pose individual questions, about 5 to 8 minutes. And at the conclusion of all presenters, we will have an open dialogue to engage some of your questions. To the extent that you may have questions that cannot be addressed during this particular webinar, we will collect those questions and do our best to give feedback to all participants with answers that you may need. So with that, I will gladly, let's put the poll in the field if we could, Kristen. So as a means, we're rather restricted on, even if you have more than one that would be of interest to you, select your preferred topic for potential learning groups. So we have strategies for recruiting and retaining member practices, meeting primary care workforce challenges, multi-institutional IRB approvals, different types of PBR collaborations, including with public health, ACOs, and leveraging PBRNs for population health surveillance. And so we'll give that a little more time. All right, 70% of you have voted. If you don't mind giving a few more seconds so we can get the voting up, that would be great. All right, so while the final votes are being cast, just for your information, 20% have number 1 strategies for recruiting and retaining member practices. 32% of you identified meeting primary care workforce challenges to be of interest. Only 3% of you identified multi-institutional IRB approvals to be of interest in the learning group. 26% of you identified PBRN collaborations with public health ACOs to be of interest. And 18% of you have identified leveraging PBRNs for population health surveillance. This is very helpful information for us, so thank you very much for working with us on that. And so with that, Kristen is going to describe for today just how to submit a question. One thing to keep in mind, we will collect all the questions at the end of a given presentation, articulate them orally to the presenter, and solicit feedback. We are not going to have the offline use of posing questions and responding through the chat box. And at the end, here we go. So how to submit a question?
Thanks, Rebecca. So to submit a question to today's presenters, you can use the GoToWebinar control panel. You can type a question under the questions section and hit send as shown in the screenshot on this slide. You may submit a question at any time throughout the presentation. And during the Q&A sessions, as time allows, your questions will be read out loud and our presenters will respond. So Rebecca, I'll turn it back over to you to introduce today's presenters.
Great. So our first presenter is from the National Committee for Quality Assurance. Dr. Nancy Tirodkar has expertise in measurement development, spanning a variety of different health conditions, and including in populations for evaluation. And she directs projects related to the evaluation of patient-centered medical home and patient engagement. So a real broad experience to bring to our discussion. And so we welcome you, Dr. Tirodkar, and look forward to your presentation. Thank you.
Thank you, Rebecca. Can you hear me? Okay.
You're coming through loud and clear.
Okay.
We're just getting the slides up. There seems to be a little technical difficulty, which is all right.
Can you? Okay. Are you seeing my slides now?
Yes, they come across beautifully.
Okay, wonderful. Okay. Well, thank you so much for the introduction, and thank you very much for this invitation to talk today on this webinar. So I'll jump right in, and let's see here. Okay. So in today's talk, I'd like to give an overview of patient engagement to set the stage, hopefully, for all of the speakers on today's webinar. And then I'll talk specifically about a project we recently completed about shared decision-making in the oncology setting. And I'll talk a little bit then about the implications for the findings more broadly in medical homes. So I'll start by describing a framework that comes from a white paper that was written for ARC a few years ago by one of my colleagues, Dr. Scholey. And this white paper was written in response to the need to strengthen and expand the opportunities for patient engagement in the patient-centered medical home demonstration projects at that time, and now it's relevant for beyond the demonstration projects. So as this table shows, there are 3 levels of engagement for patients and their families. The first one is care for individual patients. And this includes developing relationships with the healthcare team, learning how the practice works, which is part of the communication and information sharing, and learning about roles for each team member and how they will work to support patients in setting and meeting their treatment goals, helping to manage chronic illness, which is self-management, helping them make decisions about their care, which is shared decision-making, and I'll talk more about that in detail a little bit later, and helping them to coordinate their care. So this is all involved in that first level of caring for the individual patient. The second level of patient engagement is engaging patients and their families in practice improvement. Patients and families can provide a unique perspective and enhance the ability of a practice to make improvement. Just an example of a practice that I've been working with on a pilot project recently told me that they were rolling out a patient portal, and in order to test it, they invited 10 patients to participate in a little trial run of the patient portal and to give the practice feedback on the layout and how understandable and navigable the website was. And based on their feedback, the practice staff went back and made some changes to the portal. So that's just one small example of how patients can be involved on a practice level and improvement. The most common way that practices get feedback from patients is through patient experience surveys. Then another way is through having patient and family advisors sit on a quality improvement committee or an advisory council to provide feedback. However, we know from prior research, and one of the papers that we had linked with the materials for this webinar was a survey that was conducted by my colleagues 2 years ago of patient-centered medical home practices. And they found that only about 1/3, about 29% of PCMHs involve patient and family advisors on a regular basis in quality improvement at the practice level. So it's still there aren't a lot of practices that do this. It's more common in larger hospital settings and medical group settings in large practices. And the third level of patient engagement is policy design and implementation. Patients and families can help policymakers identify priorities and design policies that address patient and family needs. They can also be involved at the system level to design medical home standards, or be involved in revising standards, to design programs, and to shape research around practice transformation. Another example we have is a current pilot of a medical home that we're doing for oncology practices that NCQA is leading. And the research design, development of the standards, implementation, and evaluation of these standards involves patient and consumer stakeholders at every part of that project. Okay, moving on. This slide shows a logic model for how patient engagement affects the function of a practice and leads to improvement in patient outcomes. This is adapted from a paper by Epstein and Street. In this model, the patient engagement strategies seek to support patients and families to be activated and informed participants in their own care, and to encourage practices to adopt and sustain proactive efforts to partner with patients, and to shape at the system and community level the kinds of policies and programs that are responsive to patient and family needs. At the very bottom of this slide, cost of care, health outcomes, and patient experiences. These are the three things that IOM has articulated as the aim of the healthcare system, which is to reduce costs, improve health outcomes, and improve patient experiences. So I'm going to talk a little bit in detail about one of the patient engagement strategies, which is shared decision making. I was remiss in not including an acknowledgement of our funder here, which is the Robert Wood Johnson Foundation, for funding this project. Shared decision making is where patients and providers together consider the patient's condition and treatment options and medical evidence behind the options, as well as benefits and risks of those treatment options and patients' preferences. And then they together arrive and execute a treatment plan. This type of strategy is usually used with patients who have what we call preference-sensitive conditions, which is where evidence doesn't favor one treatment option over another, and individuals' preferences and values are particularly important in choosing a course of treatment. Some examples of preference-sensitive conditions are low back pain, hip and knee replacements, and early-stage breast and prostate cancer. Shared decision-making is also frequently used in primary care with chronic care patients, for example, patients with diabetes. Some research studies have shown that shared decision-making has shown to result in better outcomes, such as lower costs, because patients may choose non-surgical, be more likely to choose non-surgical options. Therefore, there may be fewer hospital admissions and generally higher patient satisfaction because of the process which involves the whole care team. So this project that we conducted was centered around case studies of established shared decision-making programs for breast and prostate cancer. And we also conducted focus groups with patients that participated in shared decision-making services at the clinics. What we sought to do was chart out common elements for a shared decision-making process by conducting interviews with physicians and staff at each of the organizations. And we aim to learn about the patient experience of the process and what things are important to the patient in healthcare decision-making by doing the focus groups. So what we were looking for in the criteria for choosing the organizations were that they had a shared decision-making program outside of a demonstration project. 4 of the 6 places that participated in our case study project started out with a a demonstration project from the Informed Medical Decision Making Foundation. However, 2 of them didn't start that way. They independently had established this program. As you can see, we had a range of different practices. There were 3 large academic centers, 1 community-based private practice, and then 2 medical groups. So the 4 elements that we found were in common with all of the organizations that had established and sustained the shared decision-making processes were, 1, that they were able to identify patients to receive information and support from the healthcare team. 2, that they provided information to help prepare for the consultation. And I'm deliberately using the word information and not decision aids because a lot of the shared decision-making literature is really focused on decision aids. And we found that the decision aid in this process was actually, well, providing information was important, but it was not the be-all and end-all of the process. The other 2 elements were critical for the whole process to actually take place and be successful. And a lot of the information that was provided was what we call sometimes homegrown information. So the healthcare teams had gathered what they thought was the best information for their clinical populations and presented it. And they tried to the best of their ability to have it be evidence-based information that was current. So the 3rd element is the patient and provider have a conversation about the treatment decision, which includes a discussion of the patient's preferences. And the 4th is that there's follow-up and support from the team, which includes documenting patient preferences in the medical record. Organizations were motivated to establish shared decision-making processes in order to provide more patient-centered care and improve patient experiences. This was facilitated by a culture change in physician support and leadership support of the shared decision-making model. The providers and staff that we spoke to told us that the infrastructure changes they made in order to accommodate the shared decision-making process was mostly internally funded, and so not having reimbursement options and sustainable funding externally was a big barrier for them to have more widespread implementation in their organizations for shared decision-making. Providers felt it was important to establish a decision support system for patients throughout this process, which meant following them from diagnosis to the treatment decision and beyond through their treatment. They explained that presenting a patient with unbiased information, regardless of the specialty, and having well-trained staff were also key factors in providing patient-centered care. From a patient perspective, there were 3 key categories of themes that came out from the focus groups. And these were the need for good information, the need for emotional support, and the need for logistical support. And as you'll notice from this previous slide from the processes, the information and the logistical support were in this shared decision-making process, but not really the emotional support, and I'll talk a little bit more about that. For instance, sometimes helpful, because it was helpful to understand all of the options. One negative part of that was that sometimes patients felt that every specialty tries to sell what they do, and so it was sometimes confusing to have so many options. A lot of patients went to other sources besides what the doctor or health team gave them for information. A lot of people turned to the internet or articles or other books, and there was various usefulness for this information. So trusting information, being able to trust it, was a big issue for patients. Sometimes the scientific information or articles that they may receive from doctors was helpful, and sometimes it felt kind of cold. Another issue on the information was that it isn't always clear to patients whether or not they have a choice, and so especially in the case of prostate cancer, where the 3 usual options for early-stage prostate cancer are a surgical option, a radiation of various different kinds, and then active support, which was probably on the top of our list in a frenzied rush from diagnosis to surgery. They was confident in their decision. So it was kind of an interesting paradox that we found in talking to patients, that they weren't always comfortable with being responsible for their decision, and sometimes they did want a recommendation from the doctor as to what to do. And so there's this interesting paradox of where they appreciate getting the information and talking to the doctor about it, but sometimes they're so overwhelmed and confused that they don't know what to do and want that recommendation. Okay, and this last category is help preparing, logistical support, which includes help preparing for a consultation. One of the most helpful things that patients said was that if usually a nurse navigator or an intern or a care coordinator or health coach would help them to develop questions for the provider, was a very useful thing for them to go into consultation with a surgeon or an oncologist. And also having someone as a resource to explain information and answer questions was useful. The rest of the care team, besides the physician, really mattered. So if someone was really great, we heard examples of that, and if someone was really abrupt or not very nice to them, they still remembered that. And a couple of the academic centers had a high volume of second opinion patients, and second opinions were kind of double-edged, especially if the second opinion didn't match the first, and so that led sometimes to more confusion. So to talk a little bit about facilitators, again, and barriers, culture change is an essential element for achieving a shared decision-making process. In this case, there was only focus on one condition, and we found, both talking to primary care practices as well as specialty care practices, that shared decision-making programs are best implemented when there is a focus on just one condition. And there needs to be physician support for the model. Some of the barriers are, like I mentioned, the lack of sustainable funding, a resistance from providers to adopt the elicitation of patient preferences, and engage in this conversation and relationship building with patients. And then a last thing is there are very few measures or standard metrics to measure outcomes and patient satisfaction specific to shared decision making. So a lot of the patient satisfaction results we were seeing from the case study organizations were general hospital, like HCAHPS types of things, but they weren't specific to that clinic or this process. And so that would be helpful to have in order to show impact. Some of the elements of measurement that providers have suggested to us to measure would be, was the patient given a decision aid or information or not? Did the patient review the information or not? What are some of the reasons and factors that influence the patient's decision, values, and preferences? And then what was the patient's final decision on the type or course of treatment? So those are the opportunities for measurement in this area. So to conclude, in specialty settings with sustained shared decision making, the focus is on the conversation between the provider and the patient, and the relationship, and not necessarily the information. As I mentioned, information was important, but it was a small part of what was a larger process of shared decision making. The patients want to develop a relationship with the provider, and that includes getting emotional support and logistical support, as well as information. There are some challenges related to sustainability and payment, and measurement is not really happening very much in this area on a widespread level. So the implications more broadly for medical homes are that a shared decision-making process works well for a specific decision that needs to be made. And these principles of developing a relationship between provider and patient, or health team and patient, giving good information and providing a supportive team can be applied across the care spectrum regardless of primary care or specialty care. And then documentation, medical record, and measurement are two things that are important to develop in order to gain more widespread implementation and support for shared decision making. And thank you very much.
I
Thank you, Dr. Tirodkar. I have a question with respect to the logistics support. Did they also talk about the continuity or the longitudinal nature of the support? You gave an example of some patients felt like they were shot out of the canyon. Could you elaborate on the nature of logistical support being one encounter, or were there opportunities to follow up?
That's a really great question. In the processes that we were looking at, there actually was longitudinal support for patients even after diagnosis in some of the programs and not in others. So the bulk of the shared decision making occurred after a patient was diagnosed and when they had their first appointment with the oncologist or a surgeon. And so there was a lead up to that involved getting information, having a nurse navigator or health coach give the patient a call, answer any questions, send them a packet of information, answer questions they had, and then follow up with them afterwards. Now, if there were multiple visits with the oncologist, this did sometimes continue, but I think once treatment started, often this relationship with the health team dropped off and the shared decision-making process dropped off. So it really does center around one decision, but there is a period of time that there's involvement. It's not just one time.
All right, thank you very much. We'll look forward to more questions being posed after the other two presenters have made their presentations. Thank you. And next we will turn to Dr. Tumiel-Berhalter, who partners with primary care practices and their patients to design and implement research. She's engaged in Patient Voices Network, a community of educated, informed patients working hand in hand with their doctors to make decisions about their own health. And it's a fascinating I've heard her present previously. And I look forward to her presentation today. Go ahead, Dr. Tumiel-Berhalter.
Thank you so much. Good afternoon, everyone. And let's see here, just switching over. I'm not sure what happened here. Are you all still seeing the slides?
So we can see your screen, but we don't see your PowerPoint slides at the moment. Do you have them up that you can run from your desktop, or do you want? We'd be happy to show them on our end if that's easier.
Yeah, I'm not quite sure where they went. I've been having such trouble with this.
No problem. We'll show them on our end. And so just let us next slide.
Sure. Thank you.
Oh, great. Thank you.
Perfect. Okay, so I'd like to talk a little bit about our Patient Voices Network. We have several patients who are dialing in today, too, so if there are any questions that are geared more towards the patients, they are on the line, although I don't think they'd be able to respond. And we want to talk about specifically how we engaged the group in primary care and the types of activities that they're doing in primary care. Okay, next slide. So the network is a partnership between providers, patients, and the university's research arm of the Department of Family Medicine. So we started out really as a research project, and as our group evolved, really brought in kind of that triangulation of working together with the providers and the patients and the researchers to make sure everyone was on the same page. We found that we were really able to get so much more done that was a win for everyone that way. We have the Patient Voices Network have patient action teams for each of the practices that they're involved in, and they meet on a regular basis. Right now we have about every other week we're meeting. We have a steering committee that also meets once a month, and then project team meetings that occur intermittently in that as well. So the group of patients provide feedback to the practices and partner with UB in practice-based research projects. So the group has really taken on a life of its own in terms of the activities that they're involved in. And what started out as, again, a research project that was funded by the National Institute of Minority Health and Health Disparities, where we focused on cancer, but the patients got to choose which cancer, and they chose colorectal cancer. Now we're seeing that shift where the ideas are really generated from the Patient Voices Network, and we're able to find resources or write grants to be able to do those projects. And it's also become a standard in these practices where we'll get a call and say, when's your group meeting? I need some advice on X. And so I want to give you a few examples of how we've worked together to do that. So next slide, please. So just a little bit about our practices. All practices are part of the Upstate New York Practice-Based Research Network. They're all safety net sites in low-income urban communities in Buffalo. We had 3 sites that were established in 2010 with that first grant, and we have currently added 1 new site that's really getting up and running now, and have had other conversations with other practices who are interested in having groups formulated as well. Right now, most of the patients are African American and low income, female, and most are 40 and above. Most have multiple chronic diseases. And again, as I mentioned, we have a steering committee that right now represents 3 of the practices with, and they establish kind of the network policies, things like how we interface with other researchers, what projects the group gets involved in, how are gift cards distributed, all those types of things that would be consistent across the groups, even though each PAT and each practice runs a little bit differently. And so the map on this slide shows you where our practices are. So we have Cleve Hill Family Health Center, which is on the east side of Buffalo, Jericho Road Family Practice Center, which is east side, and Jefferson, which is east side of Buffalo. And then Jericho Road Family Practice on Barton Street is on the west side of Buffalo. And that's really a unique practice because about 50 to 70% of that practice is refugee patients from about 70 different countries, speak all different languages, have interpreters on board as a regular part of their staff, and have really created some interesting opportunities and partnerships to help work with those populations as well. Okay, next slide, please. So I certainly am not going to go over this, but this is sort of our history in terms of where we started in 2009 when we submitted the grant. That was also about the same time that our practices were pulling together focus groups for their PCMH and certifications and recognition from NCQA. And just sort of, you can see how kind of our momentum has grown over the last couple of years and things that we've gotten involved in. But I just want to hit on a few things instead of going through all of our timeline. Next slide, please. The first is for practice improvement. We have created a project with Komen Foundation funding to increase mammography in primary care. And you can see in the photo there are 2 of the patient ambassadors who are members of the PATs. They are incredible women who have really become passionate about helping women get screened. And behind them is a mobile mammography unit that is co-sponsored. You can see the Sabres logo there. The Sabres Foundation is a big supporter of the foundation and the mobile mammography unit. And we help bring those pieces together by linking the practice with the community partners that operate the bus and the patients, where we have the bus go out to each of the practices once a month, and women from the practices are scheduled at some practices by the patient ambassadors, and then they're there that day to escort the women on the bus, register them, so it doesn't have to be an added activity for the practice staff. And they recruit women off the street to go get screened. It's become a staple, and the practices have really come to rely on this. So it's something that we've all seen a win from, and we've seen about a 10% increase in mammography rates in the first, say, about 8 months of the grant, and have screened over 800 women to date for just in the first year. And so we are continuing this project on, and all the practices are committed to continuing that. So next slide, please. We also have research projects that we work on, and here's just an example of one also funded by the National Institute of Minority Health and Health Disparities to address patient self-management, particularly among patients with 2 or more chronic diseases. And this was very important to the group. As I had mentioned, many of them have multiple chronic diseases and know that the disease-centric model is so conflicting sometimes in really trying to help patients make a change or to manage 2 varying conditions. So, as I mentioned, they developed a colon cancer intervention. And what was really interesting about that is all the barriers that were identified in the system that the primary care providers weren't aware of, so that they would refer and patients would go to follow up and get hit with so many very unusual barriers that once we were able to communicate that back to the primary care physicians, they were able to change their referral patterns to make it easier for people to get screened. This particular grant, the patients helped write all of our Komen funding grants. We put them up on a board and write together. They've developed this tool here, a patient action plan, to be used in the practices, and it's not only were they vetted by the patient's action teams, but also by the practice staff, so that there was agreement in the type of information that needed to be included in these tools. We've helped with practice feedback surveys. We've been developing a chronic disease self-management survey. And right now, we also have a small grant from the American Academy of Family Physicians to get men involved in prostate health and learning what they would like to speak to their primary care physicians about. Okay, next slide, please. We've had quite a lot of educational opportunities. Not only have we had a lot of medical students and graduate students work with our group, but I think one of the most powerful examples is with residency training. We have had several opportunities to talk with providers and particularly the residents about how patients would like to be communicated by, what some of the satisfaction and the cues for satisfaction are. And so we developed a skit, and this was from a patient's personal experience with a resident that we've been able to present. In this photo down here, I am in the sleeveless dress, and Pam is wearing a black top. And Pam is a patient who played the doctor, and I played the patient, and all of the people sitting around us were the residents. And they really liked that. They really enjoyed that communication. And in some areas where there couldn't be a fix, or maybe it's barriers that patients didn't understand in terms of how residents interface with the attendings and with the health system, it opened a dialogue that I think was really powerful. And so the residents have been open to us coming back as often as we can. And these are just some of the examples of comments made by the residents. They'll be more respectful during patient encounters, that they need to stop and get to know their patients. It's not just about caring for their diabetes or their heart disease. And really listen to the patient and what are critical to them in making their decisions about their health care. Next slide, please. We've done a lot of community events. One event was a breast cancer awareness walk where the patient action team members said, you know, people aren't going to go out to an American Cancer Society or Komen Walk where you're raising funds and doing things, but we need to get the message out to the community. So for 2 years in a row, we canvassed the neighborhood, and then we had a walk that ended with a big health fair type venue. But the walk piece was really critical. It went around the East Side community, and in fact, when we got all the permits to use the park, we get comments from the city like, oh, well, no one ever uses that park anyway, so it'll be available whatever day you want. And that's exactly what we wanted to do, go into the neighborhoods where they really needed resources, and it was the patients that really engaged other members of the community to come to this event. So, of course, we do tabling events at different health events, community outreach, and offer community education on different aspects like diabetes or nutrition. Next slide, please. And the group is always there to help out. We've gone into, members of the team have helped to prepare educational materials for diabetes program, get things together for the mammography project, prepare for the mammography walk. So before, in the beginning, when we were two separate groups that were trying to come together, now it's like, okay, we need to really get things going here. We've got 200 packets to put together. Let's spend an hour and just put some music on and get some materials together. And it has really become a team effort. We do, in all of our grants, write in stipends or gift cards for anyone that helps. Although this group did, for about 8 months, we didn't have any funding. We were in a lull where we were looking for other resources. And over 20 members of the PAT stuck with us and said, we're in it if you're in it, and really work to get things going again. And so the money isn't the driver. It's the mission that is the driver, but it's also very much, at least from my end, I feel like the work that's done is so incredibly valuable, and everyone works so hard that anytime we can find resources to support members of the team, we need to. Next slide, please. So again, we have had, I've given some of these presentations before, and it's always like, well, you have grants, and so you're able to support some of these initiatives. And really, I think we could very easily do this without any money at all. It would require some in-time effort and definitely a commitment. And I think we've seen that with the providers that we've worked with, too. They are so committed to this, and that is one of the things that fuels that mission, that we're seeing how we're helping improve care for other people. Definite relationship building and learning about one another and celebrating. We have usually a picnic and a Christmas party, something to celebrate all of our successes, and recognizing the role of each individual. We as researchers might have the technical skills, but the context and the life experience that the members of the Patient Voices team brings is absolutely invaluable. And providers can give us so many other areas, so much education and so much knowledge about the system and how it works, that it all fits together. And one size doesn't fit all. We need to recognize the individual practices and the communities and see what is similar and what we need to do differently. And the recognition that the patients want to help. They want to be part of the solution. And so we need to recognize that, and we need to build on that and offer opportunities for patients to do that. Next slide. And so in closing, I do want to acknowledge the practices that we work with in the UniNet, and of course all of our funders who have really been instrumental in helping us to deliver products, not just talk about them. It's the action. And the action in the patient action team is really the key word, because it's about getting something done. And that's what this group is all about. And we've realized that the more closely we work with the patient, the practices and what their NCQA and their PCMH alignments are and where their priorities are, the more we're getting done. And so that's why we're also seeing that increase in activities, because we've really been able to see a win-win for everyone. Next slide. And that's it. And this is one of our celebrations.
Wonderful. That was a great presentation, and if this was a traditional phone, it would be lighting up with several questions. So maybe I could pose one of the questions now, and we could talk about some things later on in the open session. For example, some of the participants would like to have yours and the other presenters ideas of where should they go, some references, how can they start, were there evidence of best practices for patient engagement as you've articulated they could refer to. Maybe we could talk about a little bit later. But in this window, could you talk about how the patients were selected, the extent to which they were retained and trained, and how much turnover did you have in patient engagement and the actual patients?
Well, this will actually surprise us. When we started out in 2010, again, it was a research project, so we created registries of patients with 2 or more chronic diseases from the practices, and we looked at the appointment scheduling to see who was coming in. And when they were about a week before their visit was coming up, we sent a letter inviting them, telling them that there would be somebody in the practice when they came for their appointment to talk to about the opportunity. And we got permission to contact that way. So we did have staff in the waiting room. It was a real manpower intensive way to start. When we had our first meeting for each of the practices, we had about 40 people show up, which floored me because I would have been happy with 5. And at that point we consented, we held meetings in the community, and each group had one group had about 25, the other about 12, and the first group started with about 6 that were consistent members from that 2010 group. When we didn't have any funding or stipends to give out, we still had about 20 of the original members, and still do to this day. So we have had 20 to 25 people from the very first meeting that we've ever had who are still participating. We've since then have made it a much more open door thing where people have brought family members or people have identified other practices, other patients in the practice through the mammography bus initiative, and have just invited people. We've had providers say, this person would be great, can I give them your information to call you? So now it's certainly not as kind of protocol driven. Now it's really about getting the people who are interested. And in fact, the patients, one of the steering committee decisions that was made was to have gift cards available only after somebody had attended 5 PAT meetings. The idea is that we don't want people to come for the meeting, or for the gift card. We want people to come because they believe in the mission and what we can do. And that's something as researchers that is something that I would never have come up with. And so that is something that the patients decided on, and that's how we run our groups now.
Very interesting. We look forward to learning more in the open discussion. And she recently wrote 2 monographs, Measuring Medical Homes, Tools to Evaluate the Pediatric Patient and Family-Centered Medical Home, and Positioning the Family and Patient at the Center, a guide to family and patient partnerships in the medical home. So we've already answered 2 of the questions that would be posed. Where can I have references to look at best evidence for how to implement patient engagement? So welcome, Dr. Malouin, and we look forward to hearing from you.
Great. Thank you so much. I'm really excited to be able to present this work that we completed a few years ago. So I'm going to be talking about, can you see my screen? I just want to make sure.
Looks beautiful.
Yes. Okay, fantastic. So I'm talking about a special case of patient engagement because we were working with pediatrics. And so in the pediatric community, the family is as important, if not more sometimes, than the patient in terms of decision-making and engaging in care. So that's what we'll be talking about. Oops, pardon me. Okay. So first I'd like to define family-centered care, and this comes from the Maternal and Child Health Bureau. So family-centered care is defined as assuring the health and well-being of children and their families through a respectful family professional partnership. It honors the strengths, cultures, traditions, and expertise that everyone brings to this relationship, and it's the standard of practice which results in high-quality service. Now, interestingly, when the joint principles of the patient-centered medical home came out, the AAP, or the American Academy of Pediatrics, chose to retain the principle of family-centered care as one of the core principles of the patient-centered medical home for pediatric practices. So this is kind of an important differentiator. Furthermore, there's a lot of evidence for the importance of family-centered care in pediatric care, particularly for children with special health care needs. There's been a lot of outcomes associated with the receipt of family-centered care, such as greater anticipatory guidance, reduced unmet needs, less delay in health care, reductions in health care costs to the family, reduced odds of emergency department visits, and increased odds of medical home visits. However, among children with special health care needs, only about 65% of families report receipt of family-centered care. And among children nationally, not just those with special health care needs, there's racial and insurance disparities in the receipt of family-centered care, with Latinos reporting less receipt of family-centered care than both Caucasians and African Americans. And only about 58% of publicly insured children report receipt of family-centered care, compared to 76% of privately insured children. And across states in national surveys, family-centered care is the medical home component with the lowest prevalence for those with either public or private insurance. So it is quite important. So given that, we were very interested in learning more about it and what was sort of going on across the country, particularly best practices in providing family-centered care. There's a lot of national and state initiatives promoting this concept. Yet, as I've mentioned, large proportions of families continue to report an absence of it within their care. So we were curious, what are the best practices, particularly structures and processes within practices, sort of following the Donabedian structure process outcome model that promote patient and family-centered care. So working with the American Academy of Pediatrics and their National Center for Medical Home Implementation, we received funding through a cooperative agreement, which they have with the Maternal and Child Health Bureau, and that enabled this work to be done. So we first organized a team, and we looked at the national experts in this area. So we had representation from the AAP, from the Institute for Patient and Family-Centered Care, from the Maternal and Child Health Bureau, the National Partnership for Women and Children, and of course Family Voices. And they worked with us to kind of determine what we would do around this area. So our methods were, we first sought to solicit nominations for practices that really exemplified best practices in family-centered care. And so we sought these through listservs from the American Academy of Pediatrics and the Maternal Child Health Bureau. We actually had review criteria that this team that I just mentioned used to select the practices, really following the criteria that the Maternal and Child Health Bureau has come up with for defining family-centered care. And we selected practices and invited them to participate in 30 to 60-minute key informant interviews by who they considered to be the most knowledgeable person in their practice. And then after that, we asked the practices if they would then invite a family to participate in 30 to 60-minute interviews too, so that we could get a family perspective on that practice. So these are the different domains that we used in our interviews. We asked about patient and family-centered practices, how they partner with families, what the role of families are in the practices, what kind of structures and processes that they use in their practices, the resources that they had, whether they had funding or other kinds of resources to support their family-centered practices, and then also what they considered to be some of the outcomes of this. Such as challenges, benefits, feedback that they'd received from families, and then also how they disseminate or share learning with other practices about their family-centered practices. So from 29 nominations that we received from all over the United States, we selected 17 for interviews, and then they shared with us 11 families that would agree to participate in interviews with us as well, and we conducted all of these in the fall of 2011. So this is the map of where all of the practices are located. You can see that we had one in Alaska. They're all over the place. There's quite a few in the Midwest and the Northeast, it looks like, but we did have quite a few. And they represented a range of geographic sizes, practice types, and insurance mixes. The majority reported use of having information technology, usually an electronic health record, but sometimes just registries, electronic registries. And the majority reported that they had some form of medical home recognition, but not necessarily NCQA. This was back in 2011. And this is a slide of the most common tools that were identified in these interviews with practices. So the majority of them, out of the 17, did have some kind of periodic survey that they used with their patients and families about their experience of care. Many had translation or interpreter services. Almost all had participated in learning collaboratives and along with their family advisors. Many had a family advisory board or consultant, and you can see the list of other tools that they used. And in terms of an example of a structure, one of the various structures that came up was a care plan. And so this is actually a quote from a physician in one of the practices who said that the care plan has given organization and structure to visits by imposing the structure of the care plan to document on addressing aspects of the child's health that facilitates a systematic, disciplined approach to care in the clinical setting. But also in the management of care at home, which ultimately reduces, in many cases, eliminates the need for emergent care. It includes information such as language, religion, spiritual, cultural preferences, detailed medical history, which are reported by the patient and or parent. And from the patient's perspective, when we asked about care plans, they said, well, it's a whole kind of mini reference letter into all her health issues. So when we go to the emergency, I make sure I carry the care plan with me. It kind of helps put a physician and the nurses at ease. And then in terms of a process that was mentioned, one example was scheduling. When a parent calls to schedule an appointment, whether it's for a well-child visit or a sick visit, and this is across all patients, not just those with special health care needs, practice staff make a deliberate effort to inquire as to what issue the parent would like to discuss with the doctor during that appointment. The schedule will allot an adequate appointment length to address all the parent's concerns and maintain balance in the individual provider schedule by alternating the appointments of patients with fewer concerns with those of more complex, time-consuming cases. Through the simple process change, the practice can address the needs of the particular child and family, minimizing wait times, and alerts providers and staff to any coordination efforts that may be necessary before an appointment. And from the family's perspective, when we asked about scheduling, one person said, when I call for an appointment, they know not to put us in their tiniest exam room because it's harder when you've got 3 kids and one of them's in a wheelchair. So we have many examples from both the physician or nurse or any of the various folks who are working in these practices from their perspective, how these processes and structures work in the practice, and then we also have the perspective from the patient in this monograph. So the key findings that we found from this work are that family professional partnership and family voice are key elements in family-centered practice, that learning collaboratives help practices develop shared philosophy and to learn and test new strategies around family-centered care. And other common and emphasized processes and tools include a family-centered practice mission statement and continuous quality improvement to implement additional structures and processes important to families. There are potential policy implications that came from this work, too. We really found that funding really must be allocated to increase the implementation of family-centered care and practices. Learning collaborative opportunities in which family and professional teams work across settings can jumpstart change. The family-to-family health information centers that have been funded by the federal government have provided key resources for implementing family-centered care, and measurement tools really should focus on key processes and structures associated with family-centered care, particularly those around the medical home. So I just wanted to share with you the cover of the monograph. It's available for free, and this is the link if you have an interest in learning more about this work. So. Thank you so much for your time, and I'd love to entertain some questions.
Great, thank you very much. So we will also, when we send out the PDF file of all 3 wonderful presentations, we'll have an abridged bibliography of some of the references with the help of the presenters. So you talked about there being 11 families engaged. Could you explore in your experience some of the cultural sensitivities that are considered in strategies and guidance for engaging patients and their families?
Well, one thing, we couldn't actually contact the families without their permission through their practice because of HIPAA violations, clearly. But, we were talking to practices from all over the country. And, for example, one patient only spoke Spanish, and so we actually had to engage one of my colleagues who speaks Spanish fluently to even be able to interview that family member. And so, in terms of the research, that was a bit challenging. But and we actually didn't have a lot of funding, so we weren't able to actually reimburse the families. But we were amazed at how excited they were to talk to us and to share their experiences and to share their opinion of many of the things going on in these practices around family-centered care. So that was really, really exciting, and our team really enjoyed that. And then we've kept in touch with them and shared the monograph with them, of course, too. And before we published the monograph, we, of course, shared everything that they said in the monograph with them to make sure that we had captured everything appropriately.
Wonderful. And I was wondering, are the patients aware that they're in a practice that is a patient-centered medical home?
That's a question we didn't really ask. I don't think that they were as concerned about that as much as, sort of the structures and processes that enable them to get the care they need. As far as the recognition, that didn't come out as very important from their perspective, but it did from the practices. Many of them who were recognized were very proud of that and the work that went into getting that recognition.
Right, wonderful. Based on all your experience, if there was some insight you could share to some of your eager colleagues who want to know how to get ready to engage patients in a meaningful fashion in the conduct of research or in participation in helping practices improve either of those formats, what is one thing that comes to mind that you wish you would have understood more fully when you embraced this particular this topic area?
Well, I think that, there's been a lot of work going on around medical home in these practices, and how physicians view it. I think it kind of touches on the last question, and how patients view it is so very different. So when we talk about, scheduling, you can see just from the example I gave, the physicians are looking at it in such a way that's so different than from how the families actually realize that when they come in for the practice. And that was kind of eye-opening, and that's a paper that we're working on right now, actually, is the different perspectives of these processes and structures that are being put in place in practice. And I think that probably deserves a little bit more exploration by the research community. I don't know. Does that answer that question?
I think that's great. So for folks out in as listeners, and there have been questions that have been posed, please take a few minutes to articulate some additional questions to any of our presenters, and we'll open it up to all three presenters. One question came in earlier. It was spoken about with respect to the role of patients on review committees and patients on the boards. And in particular, how does the patient voices group relate to, in the patient engagement that happens there, how does their role in the patient voices intersect or overlap, or does it, with any of the review committees and boards that may be active? Could you just clarify, Dr. Tumiel-Berhalter?
Yes. In terms of boards, they have, as I mentioned, they've done things for the practice, like reviewing their their patient financial policies. So right now there's not someone that sits on the board, although that would be a wonderful addition. But they certainly are advisors to that board when we have our faculty that are involved in some of the decision making. Things like, we need to make the entranceway a little more appealing, things like that. They've also been asked to help with patient satisfaction surveys. So they don't have an official role on the board. Would love them to have an official role on the board, or the practice kind of leadership committees. They, in terms of reviewing different grants and different proposals, that definitely is vetted through our steering committee, where we have a protocol for anyone, especially with all the core grants. We get quite a few requests, and before it used to be me, I would just say, okay, that sounds great, whatever we can do. And now the researcher comes to the group, presents their work, They decide if it's an alignment with their mission, if there's somebody that's interested in being the point person, that it's really not about the research teams connecting. And there's a place for that. But if Patient Voices is going to have a role in the grant, they want to know what it is, how it's going to work, what type of resources that they're going to be, and you know, does that make sense for them to fit into that?
Okay, thank you. I'm going to, Dr. Tirodkar, there was questions both explicitly articulated and implied on how patient engagement is pursued in order to be compliant with expectations under PCORI grants. And you have experience in that. Would you care to share that with the group?
Yeah, absolutely. The PCORI grant we have is for, as I mentioned, a pilot project for a set of medical home standards, patient-centered medical home standards for the oncology setting. And in developing the proposal for the PCORI grant, we had identified partners, research partners, which included a survivorship, because this is for cancer, we included a cancer survivorship organization that has 2 representatives on our committee. And this committee that has 4 different partners, including us as the lead, basically has oversight of the research design for the entire project. So these patient advocates are on, and they're both cancer survivors. They are involved in research design. They've been involved in advising us on the development of the standards, as well as the implementation of the standards in our pilot practices and the evaluation that we're conducting on that. And so they are, they're actually, part of our lead team. So that's how we've engaged patients at every level. That's one level. And then the actual pilot practices are also right now in the process of identifying patients to be involved with the quality improvement and transformation in their practice. So they'll be involved with implementation of standards, and we're basically requiring that as part of the pilot because of PCORI's mission.
And do you have some resources you could share, if not on the call, subsequent to the call, of how the training is being conducted?
Yeah, and that's really interesting because we're actually doing the training for the patients in the next couple of months. And so even if I don't have it right now, I will have something in the next month. But I'll definitely keep that in mind as a note and share with you whatever I have right now.
That would be fantastic. And also, we do keep track. We can also share through the PBRN listserv additional information because this is an important topic. If you would be so kind as to share that with us in a couple of months or later as you have updates, that would be most welcomed. Okay. We also were wondering about, we talked about the differences in the cultural of the patients, but perhaps you all could address the differences with respect to the characteristics of the practices in which the patient engagement is occurring. Do they tend to be federally qualified healthcare centers? Do they tend to have small practices, medium-sized practices? Does the configuration of the size of the practice and the type of payers that are represented in the patients make a difference in the patient involvement? Would any of you care to discuss that? Perhaps that might be more natural reflection from Laurene?
Yes, there's our 4 practices right now are all, well, one is owned and operated by UB Family Medicine. 2, the Jericho Road practices have just become a federal community health center, federally recognized community health center. Up until then, they were just a private practice in these very underserved communities and have just blended to, they have an arm called Jericho Road Ministries, which helps with a lot of the programming, a lot of programs for refugees, so now those 2 are blended into the community health center. The 4th practice is primary care that's staffed by UB Family Medicine doctors, but is actually owned and operated by a hospital. So all very different models. And I think across all of them, it's really that commitment and the, if the providers feel that it's valuable and communicate that back to the patients, that's really the hook there, I think. Because all the practices, the providers really value it. And I think the more that they communicate that back to the patients, the stronger the groups are.
Great, thank you. We have a statement from one of our commenters to share with you all, seeking that if you're aware of Community Campus Partnership Association, where there's much emphasis on the community partner, IRB, and sharing resources. So that may be a group that some of you may want to reach out or learn more about. And then the question was posed, was I aware of any upcoming funding opportunities? We, as funding opportunities are released, you can check on our website, and I strongly suggest that everyone, as a matter of course, is on the listserv for updates to our FOAs just in general. That's a good position to be in. Dr. Malouin, is there something else that, in hearing the discussion, that you would like to reflect on or advise us about?
Well, I think in the last question that was raised about the types of practices, in our study, we actually had a wide range of practices from, solo practitioner, privately owned practices to federally qualified health centers to, practices that were within large health systems. And I think I agree with the other speaker that the philosophy that the practice has is so important, and that many of the practices that were involved in our study all had mission statements, and actually, as part of their hiring practices, made sure that they oftentimes had a patient on the hiring committee for any staff in the practice, so that the staff would understand how important that family-centered care really is in that practice. And that just became part of the culture. And it didn't matter the size of the practice or the funding source for the practice. It was just sort of the practice culture.
Thank you. And Dr. Tirodkar, do you have something else that you'd like to share that's been prompted by the conversations that we've had? Was very
yeah, sorry, I was on mute.
That's right.
Yeah, I think that the other two presentations were really great examples of how patients can be engaged and how engagement can be implemented in the community and at the practice level.
Great. There was one question that came in that talks about how the members of the practice itself felt about engaging patients being led by some group that's external or not totally embedded within a practice. Would either of you or care to comment on that? How did the practice, I mean, we talked before about the practice culture, but are there particular characteristics of the practices or a way in which you can mitigate their apprehension from the external content or being organized, the patients being organized outside of the practice?
Yes, this is Laurene. I think that has been a real interesting challenge because it seemed like when we first started, there was this feeling of, okay, so you want us to tell on our doctors or what we don't like about our doctors. And, we really wanted to hear good and bad and all the rest of it. After we gained some momentum and I think the team started to develop the trust, it was, well, why aren't the providers here? Why are you the go-between? And so I think that has really changed the dynamic. And now, so our practice is just starting up, our Cleve Hill practice. In our first few meetings, their office manager, their nursing staff were there in the room getting started. And so very open to hearing things, and said, just say what you need to say because we want to hear this so we can make our practice better. So I don't know if there's a right answer, but there certainly was a time that our groups that were run externally said, wait a minute, we want members of the practice here. Can some of the residents come? Can some of the providers come periodically? And so that has happened, not as often as we'd like, but just because of scheduling and things like that. But I think they're very open to it now, and on both sides.
That's fabulous. One other question that's open to the group is, are there other resources that you've been able to tap into to accommodate the specific cultural needs of refugee or non-English speaking patients external to your practices or your particular grant projects? Are there other resources you can suggest people pursue?
This is Laurene again. I know we have several local resources that we've worked with. We have our International Institute of Buffalo that we work very closely with, as well as all the staff from Jericho Road. And they also have, as part of the ministry side of things, what they call the Hope Drop-In Center. And it's for people, refugees, people who they don't have to be part of the practice. Anyone in the community can go and get post resettlement assistance. So English as a second language, training classes, all sorts of different programs, or even just help navigating the access to whatever care they need. And so we've built a lot of partnerships in that arena to really help us. I mean, it was something that my eyes were really open to. I did not know a lot about the refugee community in Buffalo, and it's actually quite large. And now knowing and kind of understanding where I can go for some help has been really wonderful. And we have some great providers, some of them on our faculty, as well as the providers at Jericho, who are really dedicated to care of refugees and immigrants and are helpful resources as we move forward.
Fabulous. I have to say this has been a great presentation by the thoughtful and responsive presenters that we have had. And also because the folks on the line and on the web have posed very good questions and demonstrated great interest and engagement in the presentation and this topic. So Kristen and I are just thrilled that you're here. As Kristen said earlier, we will be sending out PDF files of the PowerPoints in a few days. Over a few weeks, we will post the presentation in a synchronized file of audio and visual. So that means that in order to cull through the PowerPoint on the website, you have to go through the file. If you find someone else, feel free, once you get the PDF file of the presentation, PowerPoint, to share widely. That we encourage you to do that. But thank you very much for letting us know your questions and for responding to our polling questions at the front. There will be an evaluation of this presentation at the conclusion, and you can obtain CME activity. So what you need to do is, it says to complete the CME credit for your participation in this webinar, complete the online evaluation at the end of the webinar, and you will be prompted to do this as you can exit the webinar, and then email the PBRN at aptassociates.com to request a copy of your CME certificate of participation. I really think this has been a fabulous presentation, and most thankful for all the presenters, Dr. Tirodkar, Dr. Tumiel-Berhalter, and Dr. Malouin. And this is an exciting topic, and so glad that you took the time to share with us your practical experiences. We will continue with our summer national webinar, where we're going to have on July 29th an economic assessments discussion in primary care. This again was identified based on what the members of the PBRN felt would be an important topic. And then we are going to have a presentation in September about good research practice, a document that's being led by Dr. Victoria Neal and a group of PBRN P30s on how to develop a PBRN, maintain a PBRN, and conduct good research. and then a variety of folks who are having their manuscripts finalized for the upcoming September release of the Journal of Ambulatory Board of Family Medicine. Particular volume for PBM will present, and we look forward to presenting an evaluation of practice transformation in November. But with your responses earlier today, we will be preparing other national webinars and exciting learning group opportunities. And with that, I just ask if any of our presenters have any last things that they want to chime in, you're welcome to do so. But barring that, say thank you very much. All right, everybody have a good day. Take care. Bye-bye.
Thank you.
Thanks.